Hello and welcome to Note to File, a clinical research podcast.
A collection of interviews, candid commentary, and general nonsense for the clinical research community.
Check us out at notetofilepodcast.com.
And now, without further ado, on to the show.
Hey guys, welcome to another Note to File, another Sticky Notes. Denali, how's it going?
Good. Can't believe it's already August. It's kind of freaking me out a little bit, having to get ready to register my kids for school tomorrow. And I don't know, man.
Yeah.
But good. Other than that, I'm tired, but
School starts next week, I think, here anyway.
That's wild to me because we don't start school till after Labor Day. So we are now registering tomorrow, and then we don't start till September.
Okay, fair enough. I wonder why. It's different.
Well, I remember when this actually passed because I was in like elementary or high school. It has to do with like summer labor forces, where like the summer tourism industry, like in Wisconsin, was very dependent on like high school laborers, and so they would go back to school in August, and then they would lose like 2 weeks because their season's Memorial Day through Labor Day for like the summer tourism season here, and so they would lose like labor on the last 2 weeks of the holiday. So they passed a law, so we start after, so they can have their high school laborers.
I'm impressed that you know the history quite so intently.
You know, the super important things that get locked in up there. Mind you, if I see people at conferences, I'll be like, "Oh, nice to meet you," and they're like, "We've met like 4 times," and I'm like, "Oh no." So
yeah, it's good. Your brain to good use.
Really important things.
Anything else exciting in your corner of the world besides being dressed like a mime?
Yeah, I look very French today. Honestly, not really. Pretty low key. What about you?
No, normal site stuff, man.
Yeah.
Every day's a blast.
Yeah, I mean, we're cranking at Vivo. We're getting ready for our summit, so that's kind of what the next month will be. So that busy, but nothing outside of the normal.
It's in about a month.
Yeah.
Exactly.
But yeah,
it's less than a month.
Slightly less than a month. Yeah, September 2nd through the 4th. So we're busy getting shit ready, which is fun.
Rock and roll.
Everyone should come. Register. It's free. You can come play in Boston.
I'll be there, which is obviously the biggest selling point.
We should put it front and center on the website. That would really bring in the crowds.
All right, settle down. All right, well, let's jump in. I feel like it's been a slow week or I've just been very out of the loop. I also feel like I haven't been paying as much attention as I normally do. But let's jump in. I think you're the one who came up with all of them this week. So
that does not mean much.
You're responsible for being like smart about them.
No, that is never the deal. I never hold you to that standard when you find shit. I never expect you to be smart about it.
And you never should. That's just smart.
Yeah, I mean, this is an interesting one. I think there's been some chatter around this, folks who are following it, but there is looking at like how we compensate participants in clinical trials. So this study came out end of July, which is interesting to me. It's a study about research studies looking at the participant payment landscape across like 7,000 some trials to see what the compensation breakdown is of trials offering compensation versus not, which I always find interesting here because I think some of it is like seems sort of obvious, I guess, to me. So whether you're doing a research study on it when you could probably just go ask someone, but regardless,
have the numbers,
right? Regardless, now we have the data, right? If you don't have the data, then it's just another opinion. But yeah, so
I think this is interesting. And obviously, like I don't have the full paper or whatever here. And I guess I could probably could have pulled that up.
I haven't read it either.
I didn't make an extra click, but maybe dig into it. But I'm actually kind of surprised by how few studies, because it says less than 60% of studies are offered compensation to participants. I obviously can't talk today. Bear with me. I mean, I almost never see a study that doesn't, but I know, we talked about before a little bit in prep, but like, maybe this includes some investigator-initiated trials or trials that are maybe just data mining. We'd have to dig in and look.
Well, yeah, I mean, we could have actually read the article and prepared.
No.
For it. But what fun is that?
We
But I
don't want to
think
set the bar too high that we actually are informed about what we're talking about.
True. But like thinking about like what does this mean? Is this like stipends or is this reimbursements for like coordination travel? Is this actual like payment for participating? But then I mean you also have people who are like incentivized because it's like free drug as part of a trial. You know what I mean? Where it's not like direct compensation, but like you're getting free care.
Maybe,
Right?
maybe.
I don't know. Anyway, the whole concept of this article is looking at like payment structure and like how participants are paid, but I think looking at like the barriers that pose here, and I think this dovetails nicely into sort of some legislation that's now being proposed, which is to say like, hey, we're paying participants, but this is still a barrier because like when we're paying participants, we're creating this barrier, especially when you start getting to like larger scale payments when they're being taxed on it, which just causes significant potential burdens, barriers for patients to actually engage and participate when it becomes an income source that they have to report as a taxable income. It gets particularly tricky when you start thinking about folks who are participating. They get compensated for a trial that shifts their income, and then they lose some benefits that they may have been accorded otherwise. So like Medicare, Medicaid, any sort of like food stamp programs, they now like flip out of those for that period of time, and it becomes incredibly detrimental on the fact they're probably doing the trial because maybe they can't afford standard of care anyway, and now they're losing other benefits for essentially a nominal dollar amount for their participation.
Yeah, and we have I have seen that.
Have you?
Yeah, I mean it's happened. It happened in a couple of studies we've done over the last couple of years. I have patients who are, two things have happened. One, people have not participated because of the threat of now having income that they have to add. And then I've had people who have like flipped out after the fact. Like we try to go to great lengths to explain to people beforehand, obviously as part of the informed consent process, that, if you're compensated over $600, it's going to be, taxed. You're going to get a 1099. But I've had somebody be like, I flip out and be like, I'm out because this is going to like put me in a bad situation. These are people who did like legitimately need,
like this could have been their best potential available option to them, in reach option for them. Have you ever had, could they have participated and not accepted payment?
I don't know. I had somebody ask that question. So hold on, I need to, for some reason my sharing is not like switching between tabs as I switch. I've noticed that it hasn't left that page. So give me a minute.
You're still on it. Yeah.
I'm going to remove it. So just bear with me. But yeah, I had seen someone ask that question, which I think is an interesting one. I mean, I don't know why someone couldn't just be like, you know what? No, don't want it.
Yeah. I'm not seeing anything, by the way. Oh, there
yeah,
it is.
No,
now he's loading.
Yeah. Well, and so I had gone from here to I did open
the actual article
a little bit. And actually, I mean, before 2010, only 22% of studies compensated patients. I mean, that seems like a wild and like honestly a pretty significant.
Do you think that has to do with like, because I should probably know this, but when did like the single IRB rule stuff come into play? Because does this become like where local IRBs, like institutional, like at large AMCs, like more hesitant to approve from an ethics perspective compensation based on coercement and shit?
Yeah, I don't know. I mean, it's a fair question.
And did it change with like central IRBs more willing to approve compensation?
Could be. It could be also that there are more, I don't know, maybe there's more private research sites now than pre-2010, which are more actively negotiating that for their patients. I don't know. I mean, there could be a lot of things, and it's probably talked about possibly in this paper, but I will say there's one thing here that does jibe a little bit, is that like procedural and device trials do tend to have less or try to offer no compensation. And I think in my experience, oftentimes that's because, it's probably a procedure a patient has to get anyway. And those visits tend to fairly mirror standard of care visit, like a visit structure. So like you're not asking the patient necessarily to take an extra trip or drive you know, an extra time to the clinic. What's up, Daniel Perez? Yeah, interesting. And IRB can approve to name another recipient for your stipend. And yeah, I can see that where patients are undocumented, that can be problematic. But I didn't realize that. I guess I've never thought to ask an IRB.
But does that have to be I'm interested, like, is that the protocol level where it's approved across the protocol, where it's like the sponsor
No, I don't
is
think
approving
so.
that, or would that
Because
be you like asking?
yeah, no, I think that would just be your site
Okay.
specifically. I would think. I mean, I've seen, again, it gets really weird because like we get budgets, we receive budgets that don't have compensation carved out, or it'll be like $25. We're like, no, we want to, like, especially here, patients drive.
Yeah, this doesn't cover gas.
Yeah, exactly. Like you're not going to take half a day off work or whatever, a couple hours at least, drive, go through all the stuff and get $20. But
it's like jury duty.
They'll say like, okay, we're not going to pay you more. You can pay it out of your budget if you want. And that's up to you. And then it's really between us and the IRB at that point, because they don't care, because they're not paying extra.
They're not paying for it.
It's just basically like sort of pass through costs. Yeah, I mean, Perez, I would mirror that. They give the site decides how to administer. I mean, although it's kind of backwards, because first we pay the participant and then we wait to get paid by the sponsor whenever they feel like paying us, which can be problematic in its own right. We've had studies that are doing $100 and we can do 200 visits in a month. Some of these like really high enrolling blood draw studies. So then you're out a decent little chunk of money. You don't want to be out 20 grand every month.
Just waiting to get it back.
Yeah. Ideally.
Can you charge? So I know, like, if you like rent an apartment and you put a security deposit down at the end of your time at the department, like if they return your security deposit, they have to do it with, interest. Is there any concept of like, hey, I paid this out of my pocket, like you were late, like I want my payment with interest?
I mean, that'd be super, but no. And I've heard people say that kind of stuff, like, oh, charge the sponsor a late fee. I'm like, why would they ever agree to that? I mean, they control the market. Like it just doesn't happen. Anyway, sorry, you had talked about it, but I didn't get tabbed over there in time.
Oh,
and I feel like we've seen this come up time and time again, and this is actually not new like legislation. I mean, this has been, looks like it was introduced in February of 24.
I think so. Again, I don't know the specifics of exactly when it is, but I know this bill is now coming up to be approved. I think this is looking to change like the 1986 regulation around this, but basically pulling it off and saying we shouldn't be taxing patients for research participants. So it'll be interesting to see where this goes. I know this is currently in like discussion on Capitol Hill right now. So it'll be interesting to see. I mean, obviously not right now. Congress isn't in session. You get my point.
No, right this very
right now, immediately. Like it's 1:15. They're talking about it. But I think it'll be interesting to see where this shifts and how we see this potentially impacting. I mean, hopefully, I can't see how like.
I mean, I don't know who would be
who's going to be
against this,
right? Like I can't imagine it's a significant revenue stream of any sort of taxes that you're getting from participant payments in the grand scheme of things.
I can't imagine.
So it'd be interesting to see. Like, hopefully, I mean, I can't imagine. Yeah, like to your point, who's actually against this? But it'd be interesting to see if they can actually get it done. So it'd be interesting to see. Hopefully, it goes through and helps.
Yeah, no, I agree. I would support that 100%. Plus, maybe my life would be easier because I don't have to issue 1099s at the end of the year and deal with sending out, 100 of those all over the place, which becomes annoying in its own right. Hey, Justin, how frequently are you seeing sponsors provide something like ClinCard versus giving you a budget and allowing you to pay? I mean, I don't know. I guess I don't want to say it's 50-50, but it's maybe close to that. Maybe a few less that offer either like a option like Green Fire or Scout or like one of the other of many vendors out there. Frankly, I tend not to like it because we have no control. And sometimes we've had studies where like those patients won't get paid for like a couple of weeks because of whatever process this vendor has to ensure the patient did their visit and all the data. I mean, at that point, there's too many layers where they can like hold that money hostage to the patient. And I do feel like, for better or worse. I mean, to be able to pay the patient the day of their visit and they have it in their pocket by the time they leave is it's a retention tool, I guess,
Yeah. Well, and I think also like, I mean, this is probably true for sponsor tech in general. You have less control over when it's paid, but how it's structured, because whoever implements the system is the one controlling how it's built and where the checks and balances are or whatever. So if that's not you, that's the CRO or that's the sponsor, it's going to be tricky.
It's not ideal. I wonder about this. Removal of taxes equals more professional participants.
So people who just participate in trials just save for the money. So this is like one of those.
Even then that has, and I don't know, maybe you're right. I guess if, I'm not taxed, now I can go out and do $100,000 worth of being in clinical trials, but I don't know.
Though, it's interesting because I know it's raised, but in my mind, yes, maybe there's a handful of folks who are going to game the system and who are going to make $100,000 doing this. But I cannot imagine. It's maybe I shouldn't make this parallel and crosswalk, but voter fraud. Yeah, there's going to be a handful of folks who do this and who have poor intent, but grand scheme of things that are actually going to make any meaningful, sizable impact, it just doesn't seem like an actual impactful risk.
Yeah, maybe. I don't disagree, but I don't know. You hear about stuff. I mean, I live in Oklahoma. There's not enough research sites to even do that, but maybe places like Florida where, are supposed to, you always hear about all the craziness. All right, Justin, we'll see. Maybe we'll get you on here. We'll see your data. We'll see your data. No, I mean, it's interesting. It's interesting. And again, I'm not certainly willing to be wrong about that, but all right, Justin, I see you. Anyways, we'll see. We'll see if that ever gets across the finish line. Again, I know I see it posted about somewhat regular intervals over the last, I guess, year and a half or so. Mm-hmm. So fingers crossed. What else we got?
I think this is more just general themes. And I think China came up a couple of times recently, just in a number of different things over the past couple of months. But seeing significant amount of increase in clinical trials being run. I mean, there's an interesting graph in this article that sort of shows the shift in trials from the US and volume wise to China. And I think we've seen the other countries, making similar investments in the trial space. So when we talked about this a couple months ago, Mexico is investing in their clinical trials program. The UK has programs that they're launching to make trials more accessible and more efficient. But it'll be interesting to see, particularly with some of the political relationships between China and the US, how this works. I mean, the DOJ final rule was in effect in April, and then they had a 90-day compliance window, but basically prohibiting exchange of information into specific countries, which was China, Russia, North Korea. There's, maybe a couple others. But it'll be interesting to see, as we look at restrictions of data happening versus pivoting of trials outside of the US, how is that going to impact efficiencies and progress and exchange of information and data, which I find fascinating.
Yeah, I mean, again, I find it all interesting. I'm not admittedly that tapped into a lot of the outside US stuff, but I think especially like you mentioned, given the stuff that's going on now, and interestingly here too, it mentions that, I mean, they're cheaper. It's just cheaper to do trials in China. And then I know we saw recent, I wonder if this will have any effect, but that they're going to start requiring more US patients in US approved trials.
Yeah.
I did notice in the article that it said something 70% of the trials going on in China are single center in China for Chinese companies specifically. It's a pretty high number.
Right.
So I don't know if that'll affect, US research much at all.
Well, I guess I admittedly don't know as much about how that the final rule will affect this. That's more so US data moving over.
That's way over. Yeah.
I don't know how much of the other bidirectional that's going to impact, but I think in general, I think the concept of research being lifted and shifted away from the US is fascinating because we're no longer particularly as friendly to some of this stuff right now. And so as infrastructure and stuff is built out elsewhere to support and to like pivot and shift the research to other locations where it is cheaper, it is more efficient, it is just more research friendly, like what's the long-term impact of that going to be?
Yeah. We'll find out, won't we? Hi, Irina. Probably said your name wrong. Many apologies, but large universities do not pay stipends, but they do reimburse mileage. If it exceeds 40 to 60, 1 or 2 nights in a hotel, covered by the sponsor. I don't know. I wonder if that's like universally true. I feel like I'm trying to remember back to my university days. I want to say we paid stipends.
I mean, wouldn't that be dictated more so like to the point like if you can, like how you pay, but like isn't that like more at the protocol level where it's like you determine if you're going to pay or you just not like
it's not dictated in the protocol.
It's just how you negotiate. So are we saying that like large AMCs just don't bother negotiating it?
Well, I don't know. I don't know if that's an IRB thing. Possibly local IRBs, as you know, can be a lot more
stringent.
Yeah, a lot more stringent. Also, I mean, I guess it would be interesting to go back to that paper and see how they define that. Like, does mileage reimbursement count?
Well, reimbursement and stipends are generally handled differently, even from a taxation perspective, in my understanding.
Yeah, I suppose that's true. But anyways, yeah, that is interesting. Okay, what do we got? We got one more. Sorry, I'm not good with my Alt tab.
Yeah. I think this one's just fascinating. It's something that I'm particularly passionate about, and just women's health in general, considering it's an area that's significantly underfunded from an R&D perspective outside of oncology, which you take out breast cancer, right? Like, I think it's great to see that we're seeing investments in this. I mean, it's the next like 5-year investment through the Gates Foundation, the tune of, $2.5 billion in, specific areas in global women's health, which again, I think there's a stat in here that basically says like less than 1% of R&D spend.
Yeah, I was honestly shocked. I will say, I mean, in fairness, as I think back, I mean, we don't see a lot of, women's health studies, period. At least I haven't. Not an area we specifically worked in a lot anyway, but maybe it's because there hasn't been a big pipeline because there's not a lot of funding towards it.
Well, right. And I mean, I think we had it until the early 90s when women weren't even required to be participants in clinical trials. So let alone doing research specifically for women, while disgusting, is not surprising. But I also think it's also interesting too, when you think about like, and again, you sort of gets into the topic of women's health period and how we're looking at that from an R&D perspective, because this is kind of talking about bikini medicine in a way. Like you're thinking about women's health, like where is covered by the bikini, that's women's health.
Yeah, right.
When in actuality, women's health is all health for women, right? Like heart conditions, like all of it is technically still women's health, and it should be researched and treated with in the same general sense, and like but we're just not even researching that. And then specific women's issues that are solely for women are even less research, as we're seeing here. So exciting to see that this investment here, interesting that it is a global initiative. So again, to what we just talked about, it'll be interesting to see where this actually is focused, but excited to see that this type of thing is happening. Although interesting, like within the US, how this will be responded to, given that the words like woman were included in the DE&I things to like pull grant funding.
Yeah, I was gonna say, be careful. You're getting awful close to DEI, and then
yep,
that money goes away.
Yeah, so it'll be interesting to see like how that balances in the US specifically. But again, this is a global investment, so maybe we'll still make some progress.
Yeah, no, it's interesting. I love it. All right, we're pretty much at the end. You got anything else exciting?
I don't. Do you?
No, nothing other than a lingering cough to share. I'll be okay. I'll be okay. Cool. No, we'll be back on Thursday. Who do we got coming on Thursday?
We got Zach from Leap Cure coming on.
Yeah, that's right. I think I actually had Zach on in the old audio only days, so it's been a few years, but yeah, excited to have Zach back on, and we will, talking very slowly while I find the button I want to click. Sorry. We'll be back on Thursday. So thanks a lot, guys. Thanks, Denali.
See ya.
Thanks for listening to Note to File. We're committed to continuing to bring you independent and unfiltered coverage of the clinical trial industry.
We want to talk about what you want to hear. So if you have something on your mind, hit us up at notetofilepodcast.com.